This week on Agents of Health, two stories broke: a Mayo Clinic retaliation lawsuit and Kaiser nurses marching outside an AHA summit. And together they ask one question every health system leader should lose sleep over. Who in your organization actually has the power to stop an AI deployment gone wrong? My guest is Emily Parker, health policy, privacy, and AI governance expert. And she thinks clinical optimism about AI outcomes is beside the point if your culture punishes the people raising the flags. Stay with us. Welcome to Agents of Health. I'm Dr. Wellis, and the one thing that changed this week, the thing I cannot stop thinking about, is that AI governance in health systems stopped being a theoretical conversation. Two stories, same week, different coasts, different institutions, and they rhyme in a way that should make every C-suite uncomfortable. We're going to get into both of them today, and I want to be honest with you. I don't think we're going to walk out of this conversation with clean answers. My guest today is Emily Parker, a health policy, privacy, and AI governance expert who has spent years looking at exactly the kind of organizational structures, or lack of them, that let safety concerns get buried. Emily, welcome to the show.
Thank you, Dr. Wellis. Glad to be here, though I'll admit, the reason for the invitation is not exactly encouraging news.
No, it is not. So let's start with what actually happened. Give me the plain version. What broke this week?
Two stories, as you said. The first, Tracy Tomiko Eto, a former senior leader at Mayo Clinic, has filed a lawsuit alleging she was retaliated against after raising concerns about AI safety issues internally. The details in the complaint are significant. She was not a junior employee. She had the kind of institutional standing where, if the system were working, her concerns should have reached the right people and triggered a formal review.
And the second story?
Kaiser Permanente nurses staged a public protest outside an American Hospital Association summit where Kaiser's CEO was speaking about value-based care and AI. Their core complaint? They are being excluded from decisions about AI tools that directly affect how they deliver care. Not consulted after the fact? Excluded from the front end.
So one story is a legal action by a former executive, and the other is a labor action by frontline clinicians. Different mechanisms, but
Same symptom, yes. And I want to be careful here because the instinct, especially in a media cycle, is to treat these as two separate HR or PR problems. They are not. They are two data points pointing at the same structural failure.
walk me through that structural failure, because I want to make sure we're not jumping ahead.
Health systems are deploying AI at scale in clinical workflows, in triage, in documentation, in resource allocation, and the internal governance infrastructure that should exist before deployment is either absent or it exists on paper and has no real authority, no teeth, no protected escalation pathway.
And when someone raises a flag inside that structure,
They find out very quickly whether the governance is real or performative. In both of these cases, the answer appears to be performative.
okay, let's put some clinical texture on this, because my listeners are hospital CEOs, CMOs, CIOs, people who are actively deploying these tools. What does it actually mean for patient care when the people closest to the risk are being silenced or sidelined?
It means errors propagate. That's the blunt version. AI systems in clinical settings fail in ways that are often subtle. A bias in a risk stratification model, a documentation tool that systematically undercodes certain diagnoses, a triage algorithm that performs differently across patient populations. The people most likely to notice those failures first are nurses, pharmacists, data scientists on the implementation team.
And if those people don't have a protected way to escalate,
The signal gets lost. And by the time it surfaces, in a lawsuit, in a union grievance, in a regulatory audit, you've potentially had months of affected patient interactions.
I want to push on the clinical side of this for a moment because there's a real tension here. Most of the AI tools being deployed right now, ambient documentation, prior auth assistance, sepsis alerts, they do have clinical evidence behind them. Some of them genuinely improve outcomes. So how do I hold both of those things at once?
You hold them by recognizing that evidence of efficacy in a controlled study is not the same as safety in your specific deployment context. A sepsis alert validated at a large academic medical center may perform very differently at a community hospital with different patient demographics, different EHR configurations, different nursing ratios. The evidence gets you to the door. Governance gets you safely through it.
That's a useful distinction. But I'd push back slightly. Isn't some of this on the vendors? If I'm buying an FDA-cleared device or a validated algorithm,
Dr. Wellis, with respect, that framing is exactly what gets health systems into legal trouble. FDA clearance is a regulatory threshold, not a deployment guarantee. The moment you integrate that tool into your specific workflow, your specific patient population, your specific staffing model, you own the deployment. The vendor does not. And the vendor cleared it has not held up well as a defense in court.
that's a harder line than a lot of C-suites are drawing right now.
I know, and that gap between where the legal liability actually sits and where health system leaders think it sits, that gap is going to produce more lawsuits. The Mayo case may be the first prominent one to break through the news cycle, but it will not be the last.
Let me bring in the Israel angle for a moment because I think it's genuinely interesting as a contrast. Israel's health ministry just launched a regulatory sandbox specifically for autonomous medical AI, focused on decision-making accountability. What does that signal to you?
It signals that at least one national health system has decided the governance question needs to be answered at the regulatory level before autonomous AI gets deployed at scale, not after. The sandbox model is essentially, we will give you a controlled environment to run these systems, but accountability for every decision the AI makes has to be traceable. Who is responsible? What is the override mechanism? What happens when the system is wrong?
And in the U.S. context,
In the U.S. context, we are largely doing the opposite. Deploy first, govern later. And the Mayo and Kaiser stories are what govern later looks like when it breaks down.
okay, I want to get into the implementation reality now because this is where I think the conversation gets genuinely hard. Emily, you've worked with health systems on governance frameworks. What actually happens when a nurse or a data scientist raises a concern about an AI system today? Walk me through what that looks like on the ground.
In most health systems I've worked with, there is no formal process. There may be a general incident reporting system, a safety hotline, a patient safety event form, but those systems were designed for medication errors and surgical complications. They were not designed to capture, this AI tool is producing outputs that I believe are biased, or this documentation assistant is consistently missing certain clinical findings.
So the concern gets filed somewhere it doesn't belong, or it doesn't get filed at all.
Or it goes to a manager who doesn't have the technical literacy to evaluate it, who passes it to a director who also doesn't, and eventually it either reaches the C-suite as a diluted, decontextualized summary, or it disappears entirely.
And the person who raised it,
Watches nothing happen. and then has to decide whether to raise it again, knowing that raising it once produced no result and possibly some professional friction. That's how you train an organization to go silent.
That's a specific failure mode. But here's where I want to push back on your framing a little, Emily. You're describing a governance failure, and I agree it's real. But is it fair to characterize Mayo and Kaiser as bad actors? These are sophisticated institutions with patient safety cultures, JCAHO accreditation, entire departments dedicated to quality. Is it possible this is more about the speed of AI adoption outrunning governance capacity rather than deliberate suppression?
Those are not mutually exclusive. And we move faster than our governance could keep up is not a defense that protects patients or employees. But more specifically, in the Mayo case, the allegation is not that governance was slow. The allegation is that concerns were raised, reached people with authority, and the response was retaliation against the person raising them. That is not a capacity problem. That is a culture problem with potential legal consequences.
Okay, that's a meaningful distinction.
And the Kaiser situation? Nurses were not asking for a seat at the table after the fact. They were asking to be included before deployment. That request was denied. Someone made that choice. And now it's on the front page.
So let's talk about what that choice costs. Because I think some leaders listening are doing a quiet calculation. The cost of slowing down deployment, the cost of building out governance infrastructure, versus the probability and cost of a lawsuit or a labor action. How does that math actually work out?
The math is worse than most leaders think. Imagine a mid-sized health system, 500 beds, regional, that deploys an AI-assisted triage tool across their emergency department. They do a pilot, they see promising throughput numbers, they roll it out system-wide.
Okay, I'm with you.
6 months in, a nurse practitioner notices the tool is consistently under-triaging patients who present with atypical symptom patterns, which correlates with a specific demographic. She reports it through the general incident system. Nothing happens. She escalates to her manager.
And
She's told the tool is validated and to trust the system. She escalates again. She's now being described internally as resistant to change. Sound familiar?
that's the shape of the Mayo allegation.
Exactly. And then one of those under-triaged patients has a bad outcome. In discovery, every one of those internal communications surfaces. The nurse's reports, the manager's response, the resistant to change label. That is not just malpractice exposure. That is punitive damages exposure. That is a regulatory referral. And the cost of that scenario is orders of magnitude larger than the cost of building proper governance before deployment.
Let me ask you something that I think is genuinely contested. You've talked about formal escalation pathways, protected reporting, real authority to pause a deployment. But in a health system under enormous financial pressure, labor costs, reimbursement compression, margin pressure, the AI tools are often being deployed precisely because they're supposed to help with that margin. If you build in governance that can pause or kill a deployment, you're potentially pausing a financial lifeline for some of these systems. How do you answer that?
I answer it by pointing out that the framing assumes governance is an obstacle to deployment rather than a condition of safe deployment. A well-designed governance structure does not exist to kill AI projects. It exists to catch the ones that are going to fail expensively before they fail expensively. The question isn't, can we afford governance? The question is, can we afford the alternative?
But you'd agree that there are health systems, rural, critical access hospitals, safety net systems, where the governance infrastructure you're describing is genuinely out of reach. They don't have a chief AI ethics officer. They don't have a dedicated patient safety data scientist. They're lucky if they have a full-time CIO.
Resource constraints are real. I do not agree that they excuse the absence of governance. And I'd actually argue that smaller systems are in some ways more exposed, not less. When something goes wrong, they have less organizational cushion. What I'd say to a rural critical access hospital is, your governance structure doesn't have to be elaborate. It has to be real. It has to name who has the authority to pause a deployment. It has to have a reporting pathway separate from the line management of the people deploying the tool. And it has to have actual whistleblower protection language in writing. That is not $1 million infrastructure investment.
That's actually a more accessible frame than I expected from you.
I'm practical when the situation calls for it.
Okay, but here's where I'm going to push back again, because I think you're making this sound more tractable than it is. A policy document with whistleblower protection language is only as good as the culture that enforces it. And if the culture, as you're alleging in the Mayo case, is one where raising safety concerns leads to professional retaliation, then the policy document is wallpaper. So, what actually changes the culture?
Leadership accountability. Not leadership statements, leadership accountability. There is a difference. A statement is, we value psychological safety and encourage all employees to raise concerns. Accountability is, when someone raises a concern about an AI system, there is a documented, time-bound response process, a named individual who owns the response. That individual's performance review includes whether concerns were handled appropriately.
And if the response was retaliation,
there are consequences for the leaders who allowed that to happen. Right now, in most health systems, none of that exists, specifically for AI. There may be general ethics hotlines, but AI-specific governance with teeth? Rare, and getting rarer relative to the pace of deployment.
I want to come back to the Kaiser nurses story specifically, because I think it raises a slightly different dimension. The Mayo case is about a senior leader being allegedly retaliated against. The Kaiser case is about frontline clinicians being structurally excluded. Those are actually different governance failures, even if they rhyme.
They are different. The Mayo case is about what happens after you raise a concern, the retaliation failure. The Kaiser case is about what happens before a concern even needs to be raised, the inclusion failure. If nurses had been part of the AI design and deployment process from the beginning, they would have surfaced concerns as design decisions rather than as protests outside a conference.
Early evidence does suggest that user-centered design in clinical settings tends to produce better implementation outcomes, though I'd want to be careful about how strong a claim we make there.
Fair caveat. But even setting the outcome data aside, the pattern in health systems is to involve clinical staff at the training stage, not the design stage. Here is the tool we've already bought and configured. Now let us show you how to use it. That is not inclusion. That is notification.
And the nurses at Kaiser are not wrong to be angry about that distinction.
No, they're not. And here's what I'd add. The CEO of Kaiser was at the AHA Summit talking about value-based care and AI, as though the organization is a model to emulate. And outside the building, the people delivering that care are holding signs saying they were excluded from the decisions. That reputational gap is not sustainable.
It also signals something to other health system leaders, though, doesn't it? If you're a CMO watching that and thinking, we've done the same thing, that's a different kind of warning than a lawsuit.
Exactly, because a lawsuit is a legal event. A protest outside your CEO's keynote is a workforce relations event, a media event, and a signal to every clinician in your organization about whether their voice matters. Those are harder to contain, and they tend to compound.
Let's move toward the leadership takeaway because I want to give people listening something they can actually act on. If I'm a CMO or a CIO right now, What are the concrete decisions I need to be making? And I want you to be honest about the trade-offs because I don't think these decisions are free.
The first decision is an audit. Before you do anything else, you need to know what AI tools are currently deployed in your organization, at what scale, and what the actual escalation pathway is if a clinician has a safety concern about one of them. Not what the pathway is supposed to be, what it is in practice.
How long does that audit take?
Done properly, 4 to 6 weeks for a mid-sized system. You're interviewing department heads, frontline clinicians, your data and analytics team, your legal and compliance team. It's not glamorous, but it is foundational.
And the trade-off of doing that audit is
It will surface things you'd rather not know. Tools deployed without adequate safety review. Concerns that were raised and went nowhere. And once you know those things, you are on notice. You cannot unknow them. Which means you have a legal and ethical obligation to act. That is uncomfortable, but not knowing and having it surface in discovery is worse.
the second decision?
Name someone, specifically, not a committee, a named individual who has the authority, in writing, with board-level visibility, to pause an AI deployment if they believe it poses a patient safety risk. And that person's reporting line has to be independent from the business units that own the AI tools.
Because if they report to the person who championed the deployment,
You don't have independent oversight. You have a rubber stamp.
and that person needs to be protected.
In writing, in their employment contract, in the organizational policy. And that protection needs to be tested, meaning the first time someone raises a concern through that person, the organization's response needs to be visible to leadership as a signal of whether the governance is real.
Here's a tension I want to name, though. If I name a person with that authority, and that person is too conservative, if they pause deployments that would actually help patients, I've created a different kind of harm. The risk of underdeployment is real too.
It is real, and I'm not dismissing it. But good governance is calibrated. It distinguishes between this concern is a legitimate safety signal that requires investigation and this concern reflects a preference for the status quo. A skilled governance officer can make that distinction. What they cannot do is make it fairly if they don't have organizational protection and independence.
But that calibration question, how conservative is too conservative, that's not resolved, right? There's no standard for it yet.
No, there isn't. And that's actually one of the things I find most concerning about where we are. We're asking individual governance officers to make judgment calls that the field hasn't established norms for yet. That's a real vulnerability. And it's one more reason why the regulatory signals I'll mention in a moment matter. Because right now, the floor is wherever an individual organization sets it.
The third decision?
Clinical inclusion from the start. Before you sign a vendor contract for a new AI tool, you need a formal process that includes frontline clinicians, not just clinical leadership, frontline clinicians in the evaluation. Nurses, pharmacists, the people who will actually use it. Their input needs to be documented. Their concerns need to be formally addressed before deployment. And if concerns are overridden, that override needs to be documented with a rationale.
Because if something goes wrong later,
We heard the concerns and overrode them without documentation is a very bad place to be.
that third piece is going to be the hardest for a lot of systems because it slows down procurement timelines.
It does, and I'll be honest, that is a real cost. Vendor contracts have timelines. Board pressure to show AI progress is real. The competitive pressure to not fall behind peer institutions is real. I'm not pretending those pressures don't exist. What I'm saying is, the cost of that slowdown is predictable and manageable. The cost of the alternative is unpredictable and potentially very large.
Let's look forward. What are the 2 or 3 signals you're watching over the next 12 to 18 months that will tell you whether health systems are actually course correcting on this?
The first signal is regulatory. The FDA has been expanding its oversight framework for AI and machine learning-based software as a medical device. I'm watching whether CMS and the OCR, the Office for Civil Rights, start treating AI governance failures as compliance failures under existing frameworks. Right now, many leaders see governance as a best practice. If regulators start treating the absence of it as a violation, it becomes a legal requirement overnight.
And the Mayo lawsuit, does that accelerate that regulatory shift, or is it too early to say?
I think it accelerates it specifically because of who the plaintiff is. A senior leader at one of the most prestigious health systems in the country filing a retaliation complaint about AI safety concerns, that is the kind of signal that lands on a regulator's desk and prompts a policy conversation in a way that an anonymous complaint does not. Regulators pay attention to named public cases. This is a named public case.
Second signal?
Labor contracts. The Kaiser protest is not the last one. Nursing unions and other healthcare labor organizations are beginning to insert AI governance language into contract negotiations. Rights to be consulted, rights to refuse to use a tool they believe is unsafe, rights to escalate concerns without retaliation. If those provisions start appearing in major collective bargaining agreements, they will effectively mandate governance structures that health systems have not voluntarily built.
That's a signal I had not fully connected. That changes the governance question from should we build this to we are now contractually required to build this.
Different conversation entirely. Watch the next major nursing contract negotiation at a large integrated system. That's your canary.
Third signal?
International regulatory precedent. The Israel sandbox is one example. The EU AI Act has specific provisions for high-risk AI in healthcare that are now in force. As multinational health technology companies start building governance requirements into their products to comply with EU standards, those requirements will begin to flow into U.S. deployments, whether U.S. regulators require them or not. Watch what the major EHR vendors and AI platform companies do in their product roadmaps over the next 18 months in response to EU compliance pressure. That will tell you a lot about where the floor is going to be set.
So, regulatory arbitrage flowing in the other direction. International standards pulling U.S. practice upward rather than the other way around.
Exactly. For once, the international regulatory environment may be pushing U.S. health systems toward better governance rather than the reverse.
Emily, I want to ask you one question before we wrap, and I want you to be honest about it, because I think it's genuinely unresolved. We've talked about governance structures, escalation pathways, named individuals with authority to pause deployments. All of that is real and necessary. But there is a version of this conversation where governance becomes an obstacle to AI adoption in healthcare, where the fear of liability and the weight of process slows innovation to a crawl at exactly the moment when AI genuinely could save lives. Is that a real risk?
Yes, it is a real risk. And I want to be honest about that because I think it would be intellectually dishonest to say otherwise. There are AI tools in healthcare that could meaningfully reduce diagnostic error, reduce medication harm, reduce preventable readmissions. If governance structures are built in ways that are bureaucratic rather than functional, if they become a series of checkboxes that slow everything down without actually catching real risks, then yes, patients are harmed by the absence of those tools. That is a real cost.
And you don't have a formula that resolves that tension.
I don't. And I don't think anyone does right now. The answer is not no governance. The Mayo and Kaiser stories make that clear. But the answer is also not maximum governance at all costs. The answer is governance that is proportionate to the risk, genuinely functional rather than performative, and built by people who understand both the clinical stakes and the organizational dynamics. That combination is rare, and building it at scale is genuinely hard work that does not have a clean playbook yet.
And that uncertainty is real, and I think our listeners deserve to sit with it rather than have us resolve it artificially.
Agreed. Though I'd add one thing. The fact that we don't have a clean playbook is not an argument for waiting. It's an argument for starting now and building as you go, with humility about what you don't know yet.
That's a harder ask than it sounds. Starting something you know is incomplete.
Most of the important things in healthcare are.
Emily Parker, thank you. This has been one of the more uncomfortable conversations I've had on this show, and I mean that as a compliment.
Discomfort is usually a sign you're asking the right questions.
All right, let me bring this home. The Mayo lawsuit and the Kaiser nurses' protest are not PR problems or HR disputes. They are governance failures with clinical, legal, and workforce consequences that are still unfolding. The pattern they reveal: deploy AI at scale, sideline the people closest to the risk, suppress or ignore the safety signals that surface. That pattern is not unique to Mayo or Kaiser. It is widespread, and the cost of it is becoming visible in ways that cannot be ignored. What health system leaders need to do, starting Monday, is 3 things. Audit what you've deployed and what your actual escalation pathways look like in practice, not on paper. Name a person with real, independent authority to pause a deployment that poses a safety risk and protect that person in writing. And build frontline clinical inclusion into your procurement process before you sign the next vendor contract, not after. None of those things are free. They slow timelines. They surface uncomfortable information. They require leadership accountability that is harder than a policy statement. And they still don't resolve the genuine tension between governance rigor and innovation speed, because that tension is real, and anyone who tells you otherwise is selling you something. If this conversation raised questions for you, and I hope it did, here's what I'd ask you to do. Subscribe to Agents of Health so you don't miss the next episode, because this governance story is going to keep developing, and we are going to keep following it. If this episode was useful to you, please like it. It helps other healthcare leaders find the show. And share it with a colleague. Share it with your CMO, your CIO, your chief nursing officer, your general counsel, whoever in your organization is making AI deployment decisions right now. This conversation is one they need to be having. And please, leave a comment. Tell me what your organization is actually doing about AI governance. Tell me where you disagree with Emily, or where you disagree with me. Tell me about a real situation you've navigated, or one you're stuck in right now. I read every comment, and if your question is one that deserves a full episode, I will bring it back to the show. The most useful thing I can do is reflect your reality back to you, and I can only do that if you tell me what your reality is. Thanks for listening to Agents of Health.